and away you go.
Awesome. I love it. Let me make sure I can share my PowerPoint with you guys because that's always the beginning. See if this works. Can you guys see my screen?
It's circulating.
It says it's starting. There it
There
goes.
we go.
Yep, we got it.
Sweet. All right. And then I need to find my little presentation button. No, there we go. All right. So I'm Dr. Piper, as has been said. I'm a naturopathic medical doctor in the state of Idaho. We call ourselves NMDs there, which is a little new for me because I came from Oregon where I was an ND. All the politics of licensure we don't have to get into, but I've been practicing in the world of fecal transplant for about 10 years now. Which has been really cool. I've learned so much about the microbiome working in the field of shit. Yes, we are going to get down and dirty. Yes, I do swear. I hope you guys are all okay with that. But it's such a fascinating field, and it has really shown me the power that microbiome restoration can have. And so I want to share as much of that with you guys as I can. I love clinical cases. I think that that is one of the best ways to learn is to hear patient stories because that's how you can connect with the medicine. So I've got a few of those thrown in here for you guys. Um, so like let's dive in and see how it goes. Disclosures, I am the senior manager for science and education at SFI Health. So I do also rep some microbiome supplements. Don't worry, no names will be mentioned in the making of this CME video. And then I also have my own private clinic, which is Biome Basics, and it's my clinic out of Idaho where I still provide fecal transplants for patients with C. diff not responding to standard therapy. I'm very into donor screening and finding the best shit I can possibly find. So, more than happy to fill you more in on that when we get into donor screening because it's something that I love. But if we're going to talk about the microbiome, we need to understand what in the world this is. The microbiome is basically an incredible organ inside of our body. And I really do think of it as an organ, especially when I'm talking about fecal transplants with people. It is 4 pounds inside of our system, and it is more than just bacteria. We talk a lot about the bacteria and how important the bacteria are. They're over 90% of the microbial organisms that live inside of our guts. But we also have amoebas, we have protozoa, some of us have parasites. We've got lots of fungus in there. It's a whole ecosystem. It's an environment of multiple different organisms that live in us to help keep us alive. We're their host, we're their home. And there's a lot of information out there that shows that their genetics outnumber our genes. There's some studies that say 100 to 1, some that say 10 to 1, some that say 1 to 1. But at the end of the day, if we think of how many we have versus how many are in existence with us, there's just like at the end of the day, a shit ton of bugs that live inside of us is what we can take away from that. I do think it's closer to 10 to 1 in terms of the genetics, but in terms of bug to cell, it's about 1 to 1. So we have 32 trillion cells inside of our body. We have approximately 32 trillion microbes that live in and on us. And the bugs are super cool. But what's really interesting, so Rob Knight is a PhD researcher out of UCSD. He's phenomenal. If you guys have an opportunity, I highly suggest checking out the TED Talk that I linked here. In that talk, he talks about how different each of us are. What's so fascinating about the microbiome is that we can actually use some of this information in forensic science to identify people because of how unique our microbial makeups are. And what's fascinating is in his lecture, he was talking about like if we took everybody who's on this call and we sampled everybody's stool and we did a whole genome sequencing of that stool, which is basically asking the question of who is there, who are the microbes present inside of your system. And we were able to lay those all out next to each other. There might be 10% genetic similarity in the names of the microbes that exist inside of our bodies, which is kind of wild to think about because we start to look at different ratios and people get really caught up in the name of the bug. I really pull back from that, especially when I start thinking about the microbiome more as an ecosystem It's more about restoring diversity and getting as many of these different microbial species in complement with each other inside of our intestines. And I also really love this demotivator because it was a part of my undergrad education. I was a chemistry major at Southern Oregon University, and our chemistry professor would literally buy calendars of demotivators and post them all over the department. And this one was one of my favorites. Just because you're unique does not mean you are useful. And I think a lot of patients feel that way when it comes to their microbiomes because they're like, cool, I've got all these bugs inside me and they're not working for me. So what do we do? Like, how do we fix that? Right. And so it comes down to really the concept of diversity and getting in more species rather than killing and identifying which species we need to eradicate. So what's really interesting is there was this study that was conducted back in 2016. And what they did was they took all of these different chronic illnesses that people were experiencing and they assessed their microbial diversity. And they looked kind of across the board, you know, if you have these different immune diseases, if you have these different metabolic diseases, if you have cancer, what does your microbial diversity look like? And basically, what they came to find was across the board, people with chronic illness or chronic diseases that are common in our Western world had low microbial diversity. So it's a way for us to kind of zoom out from all of the, like, we dive so deep into, like, what is the name of the bug? What is the issue going on with this person? Could it be this potential immune cell? And instead of going so deep into, and I don't want to like negate it, but I always call it kind of reductionist science, right? Where we get into like, what is that key finite detail that we need to dive into to figure it out? If we could just zoom out and look at this as overall, as a population, we are not getting healthier. And one of the things that's really consistent in our world is that we're losing microbial diversity. What is it that's depleting our biomes? A lot of different things. We've got medications. Various medications that we take on a day-to-day basis have been shown to reduce beta diversity. So alpha diversity is like your own internal richness, a single sample, right? And then the beta diversity is looking at your richness in multiple samples compared to each other, right? So like yours compared to somebody else's, it's a nice way to say, oh, okay, like as a whole, your biome is very rich or it's very deplete and poor. What's really interesting is that a lot of the common drugs people are on, like NSAIDs, metformin, PPIs, anybody? Everybody seems to be on those at this point in time. I do so many deprescribing protocols for PPIs. They're all reducing the diversity inside of our gut. Antipsychotics are another huge class of drugs that are depleting our biomes. And I'll talk more about that when I get to one of my patient cases. But it's something that I think we don't always think about when we're in this world. I mean, you guys are unique because you've stepped outside of the MDDO world and you're in that kind of functional realm, which is awesome. But a lot of our colleagues, a quick visit into their office, it's really easy to hand out a prescription and go to the next patient. And unfortunately, not only are these prescriptions impacting the microbiomes of our patients, they're also impacting the microbiomes of the surrounding ecology, which also has its own downstream effects, which is kind of crazy. Then we think about pesticides. I sometimes go to the USGS site. I decided not to do it for this particular presentation, but if you look at pesticide use basically from like the late 90s to now, we're on an exponential curve of increased use. We use so many gallons of pesticides on an annual basis, which is completely eradicating and killing biomes. It's killing our plant biomes. It's killing our own internal microbial environments. It's present in our water. If you look at some of the comparative studies that they've done on mice, like some of the like pro glyphosate studies, which are super fascinating, they'll go and they'll talk about how they gave these mice or rodents low doses of glyphosate. And it's like, look, nothing really happened. But then they put in like a little fine print note, oh, but like, by the way, the water wasn't fully clear of glyphosate because it's basically ubiquitous inside of all of our water systems. So glyphosate is not bad, but it's like, well, is it really not bad? Or are we just not able to test it in a true comparison fashion because we can't really eradicate it unless we're using like RO water, which has its own depleting impacts on minerals, right? But we can always remineralize. Either way, a lot of things are killing our microbiome, and they're things that we can't really control. They're outside of our control, especially when it comes to pesticides. You can look at your local park map and see how many pesticides that they're using inside of local parks. Like kids run barefoot through those grasses, and those grasses have tons of chemicals inside of them to keep them green and looking healthy. And it has impacts and major implications. Another thing here, and this is again going back to the antipsychotics, mostly because a lot of people don't think about this, but the gut-brain axis is so insanely real. And when we're talking about how to support mental health and people are getting put on antipsychotic medications, what's really interesting is that people who take antipsychotic medications compared to those who don't take antipsychotic medications have significant reductions in their microbial diversity. So again, medications, things that we're using on a day-to-day basis to try and help support, I think it's all with good intention, can actually have some pretty significant and profound depleting effects on the microbiomes of our patients. So that's all sad and depressing. And I don't always want to be the bummer here. I don't want to bring all the bad news, but I do think that what's really cool about repleting our biomes is something in the world of stool, right? We can use good shit to replace the bad shit. So I want to talk to you guys about a fecal transplant case study that I had. This was one of my very first patients when I went into practice, and I loved this woman so much. She was a female in her late 60s. She came into my office and she had been suffering with C. diff for 4 months, and she had acquired C. diff after a prescription for clindamycin after a MRSA infection. So she had, drug resistance, couldn't get over it, took clindamycin, and now had insane bowel movements, right? Like any C. diff patients come in and sometimes they're in the realm of 10 bowel movements a day. Sometimes they're more like 30 bowel movements a day. It just depends on how severe they've gotten. She was in like the 15 to 20 realm. So you really don't have much of a life when you're passing stool every hour of the day. She was not doing well. She had successfully completed 4 full rounds of vancomycin. 2 were 10-day courses, standard 10-day courses. 2 were month-long pulse tapers. She came to me at the very end of her second month-long pulse taper. Her anxiety was worsening. Her depression was worsening. This woman had been institutionalized for major depressive disorder 3 times previously in her life. Suicidal ideation. She'd had suicidal attempt. It was not a great place for her to be. And she told me in my visit with her, she was like, I just feel like I'm living in this like dark cloud of depression. And she's like, I know I'm here to talk about my C. diff, but like I'm scared because I've been there before. Like I've been in the darkness. I don't want to go back there. But every time I take a round of antibiotics, it gets worse. And so we talked about adding in some biofilm disruptors, right? Because all of our microbes love to create protective barriers around themselves. And I had her kind of clean up the rest of her vancomycin taper with some biofilm disruptors, and then add in a little bit of Saccharomyces boulardii, one of my favorites to bring into FMT cases. I use it a lot. You'll see it over and over in my case presentations. I didn't technically put it on this slide, but it was real in what happened. And what we did was we dosed her. So I gave her a 30 cap dose of fecal transplant, and she did 10 caps a day for 3 days in a row on an empty stomach. So I usually have them do some broth fasting prior, get ready for FMT. And the coolest part was I usually call my patients the day after they've swallowed a handful of poop pills or crapsules. And I asked her how she was feeling. And she was like, I don't want to talk about my poop. Is this what it feels like to be happy? And it was so profound for me because I really was calling to check in on her stool. Like I wanted to know, are you pooping solid? Like how are things going? Usually with fecal transplant within like 24 hours, I'm going to see a shift in that person's picture. And so that's what I expect. And if it hasn't happened, then I think about dosing a little bit higher and shifting my plan kind of on the fly. But this was a little bit more of an unexpected result. And it goes back to that gut-brain axis. Like it was so cool for me to have this conversation with this woman who had struggled with depression her whole life, 7 decades of her life, she had struggled with depression. And this was the first time that she was like, she was like, I'm so happy. She's like, I just want to like eat shit on the back of my shirt and wear it to Starbucks and tell everybody to eat shit. And I was like, she's just awesome. Like she was so incredibly cool. And it was so fun to help her in that time. So, what exactly is FMT? When I tell people to eat shit and have these wonderful, cool success stories, what do I really mean by that? Fecal transplant has been studied for the last, I'd say, 25 years. Early 2000s was when they really started diving into the research around fecal transplant. However, it has been around way longer than that. Its history starts in 4th century China. They used to use it for things like gastritis, except now we've got cool clinical trials that are using it for all kinds of different neuro diseases, different immune diseases. There are some really interesting trials on fecal transplant and cancer, a ton of stuff in the gastro world. I mean, it's directly related. Like we're swallowing pills and we're inserting through the tush to deliver stool to the colons of these sick recipients, which is kind of crazy. So overall, fecal transplant is the transfer of stool from a healthy donor to the colon of a sick recipient, which is exactly what it sounds like when people are like, what do you do? And I'm like, I work in fecal transplant. And they're like, you do what? And I'm like, it's exactly what it sounds like. I take stool from a healthy donor, I process it into a capsule, or like I like to call them crapsules, and I give them to a sick recipient. And I can help make pretty happy humans, which is pretty cool. I prefer frozen oral capsules. If you're doing this in a hospital setting, generally it's done through a colonoscopy. However, NG tube can often be employed too. And then most people who are trying to do DIY FMT at home are using enema delivery. There's a lot of research out there, like comparing capsules to enemas to colonoscopy. The gold standard with fecal transplant is really considered to be colonoscopy. But what was really cool is this study that was conducted by Cow in 2017 actually compared colonoscopy to the frozen oral capsules. And what they saw was that both of them were 96.2% effective. If I don't have to put a patient through prep and a procedure that has a potential for bowel perforation, I'm super interested in frozen oral capsules. The only thing that would make a person not eligible for this therapy is somebody who can't swallow a capsule. So I definitely think it's a preferred route. And it's really fun because then you can tell people that they can jokingly go around and tell their friends like, eat shit, or you can tell spouses of the person who's taking the therapy that, and it just kind of makes it fun. You can joke about it. People get jovial. I like that. When you have to go under and do a procedure, it's a little bit less exciting. How does this work? How is it that we can take stool from a healthy human, put it into the digestive tract of somebody who is considered sick, and make them feel better? Well, we don't really know how it works. There is a lot of thought and theory that has gone into how this mechanism may or may not play out. I generally think of it as being the first one here is that it's microbiome. Oh, I didn't mean to click that. I'm sorry. Microbiome modulation. So I think of it as like direct competition. We're bringing in a brand new ecosystem. It's coming in. Here's the recipient's microbiota, these little green guys. We've got the donor microbiota. They're coming in. They're basically taking over, like setting up shop. This is our house. We're moving in. You guys haven't done your job. We need somebody else on site, right? So I kind of think of it more in this realm. But what else is really interesting, especially in the world of C. diff, is we're dealing with quorum sensing type microbes. And so these are microbes that once we've lost enough of the other community members, they start signaling to each other, right? They send out these small little signaling molecules to basically be like, hey, we can do this. Like we can take over this environment now. And then they all start producing their toxins because it's a way for them to be able to basically take over the environment. Then we'll get back to the quorum sensing aspect. But I do think what's nice is that when we get this donor microbiota in, it reduces the ability for these guys to talk to each other because, again, we've got that overcrowding aspect of all of these new bugs coming in. And when the new bugs enter, it reduces the quorum sensing microbes' ability to communicate because now there's other microbes in the environment who are going to shut that down, which is kind of cool. This is an interesting aspect when we think about bile acid metabolism. Bile acids are just crazy cool across the board, and the microbes conjugate them and they make them more usable inside of our body. It's still kind of a shaky theory, but also something that could very well be playing a role. We know that some bile acids actually have a direct impact on reducing susceptibility to C. diff, which is awesome. And then this host immunity modulation, which I think across the board, the microbiome is doing this. The microbiome is what educates our immune system. It's what tells our immune system how to work. And so what's cool about the microbiome is that if we can add bugs in who are already telling somebody else's system to be healthy and to be anti-inflamed and all of those wonderful things that we want from a healthy donor, we can potentially impact and have that same effect on somebody who's not getting that signal from their digestive tract, which makes fecal transplant very appealing for things like IBD. But unfortunately, it's not legal for that, and we'll dive in there soon. So healthy donors. How the hell do you define health in this country? I think that it's become pretty clear that we live in a toxic sludge. And as much as I love to be optimistic, and I will forever fight for us to be reducing chemical exposures as much as we can, it's not the reality we live in at this moment in time. And so when I'm looking for donors, my screening questionnaire is about 6 pages long. I've got a 7-day diet diary. I've got a 7-day stool tracker. I want to know that they're pooping Bristol fours on a day-to-day basis. I want regularity. I want them to be eating well. I want them to be choosing good food. So whole foods, biodynamic, organic, as much as possible. They've got to be vaginally birthed and they've got to be breastfed. Those are big disqualifiers in my bank. If you're a C-section baby, like, do you have the potential to be healthy in this world? You bet you do. Are you the healthiest microbiome that I could use to put into somebody else's intestines? Absolutely not. And it doesn't mean that we can't help you or create a healthier environment for you, not by any means. But when I'm screening, I am literally looking for the cream of the crop. I want people who sleep well. I want people who have normal body habitus. I want them to be healthy, happy humans, right? Because we talked about just in that first case, that wonderful change of mood for that woman who suffered from depression. I also want people who don't have any diseases, like no history of disease. I also want, if possible, no antibiotic use. That is really hard to find here in the United States. It's possible, but it's hard to find. And no medications. And I think what's really interesting about the no medications talk is, this is a place where please don't shoot me for bringing it up, but it got brought up to me at at the MAPS conference that I was at 2 years ago. And I was talking about fecal transplant and having a conversation with one of the providers there and telling him about my screening metrics. And he was like, it was all around the introduction of the mRNA technology. And he asked me, he's like, are your donors vaccinated? And I was like, well, and at that time, I was screening out for mRNA technology. Too new, don't know the impacts on the microbiome, was not willing to do that with my donors. And he's like, I'm not just talking about mRNA. I'm talking about all the vaccines, like childhood and on. And I was like, wow. Like I had a moment as an ND, right? Like where I was like, you're not wrong. Like, I really believe we can have healthy kids in this world without intervention. And it was really interesting because I've got a lot of ND colleagues who've got kiddos who've been raised without vaccines, no antibiotics. Like, I'm very lucky to be part of the community I'm part of. So I can always call a friend and be like, hey, your 18-year-old daughter, does she want to poop for me? Because she was vaginally birthed, right? She wasn't she was breastfed. Great. So we have those conversations, which is awesome. But it was a conversation that I do think is worth having. And there's a provider out of UCSF, or she's out of the San Francisco Bay Area. Her name's Dr. Sabine Hazan. I don't know if you guys know her or not. But I listened to her at a conference a couple of years ago as well. And she was talking about how, because she does fecal transplant and she's got her own genomics lab where she's doing sequencing of the stool and like able to really dive into stool, like transcriptomics and all kinds of cool stuff like that. And basically, she said in her lecture, I don't know if we actually have healthy stool here in the United States. Like that was one of the statements she made. And that's how difficult it is to find healthy stool. So just wanted to throw that out there because a lot of people are like, well, I'm just going to do DIY FMT. And I'm gonna like ask my buddy over here to poop for me. And it's like, it's so much more than that. And I do think that that's above all else, please take that away from this talk. Like the donor is probably the most important part of what I do. And so I really do like to focus on this slide and stay in here because the questionnaire helps me understand who they are, what they're doing. I bring them in for an interview. I do a physical exam on them. All of that screens out. Then I'm running serum, I'm running stool testing, and then I've also added in whole genome sequencing to get a better understanding of their diversity scores. So very, 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 very important. Very important. And then here's some evidence to really kind of drive some of those key facts home. One being is that this study that was conducted back in 2021 really looked at the number of antibiotic classes people were taking. And if you had had 4 or 5 different antibiotic classes, so if you'd had 4 or 5 antibiotics in your lifetime, your incidence of type 2 diabetes significantly increases. Just looking at antibiotic exposure. Like when we start thinking about how many people in this world struggle with metabolic syndrome, obesity, diabetes, and then we start thinking about the number of antibiotics that go into circulation. Again, not just the ones that we're taking, they're the ones found in foods, right? If you go eat at a restaurant, you're likely getting a small dose of antibiotics. I actually had a patient who received a fecal transplant, was so excited, felt so good, went right to McDonald's, ate a McDonald's Big Mac, and literally recurred on me. I was so pissed. The hard part was I was very young in practice. And so when that happened, and he called me and he was like, my diarrhea is back. And I was like, what? Because like my FMT doesn't fail. Right. So I was just like, what do you mean you recurred? And then I had to really dive in. Like, what did you do? How did things like, what have you been up to? And it really came down to he went and just like totally mowed down on preservative rich, antibiotic rich foods. And it was enough. He was on day 1 of FMT. Like he felt so good immediately. He went right to McDonald's. And that now becomes part of my Part Q. Like I tell people, please do not go eat fast food, preferably ever again, but definitely not within the first month of therapy, because we need to give that microbiome, that new ecosystem, time to adjust to the new world it's entered. Vaginal birth, I'm sure you guys already know this, but I just think these are numbers that are super, super important to key in on. Vaginal birth versus cesarean delivery is so crazy to me. Vaginal birth, basically babies get a mouthful of mom stool, and in that it seeds the microbiome. A lot of people think that the uterus is a sterile environment and these babies are raised in a sterile environment. I really don't think that's true, like on any level. But I do think that that initial dose of mom stool when the baby exits the birth canal is so incredibly important in setting that baby up for a successful, healthy, immune world moving forward. And we see that in the literature. Babies who are born C-section have significantly higher incidences of things like asthma and allergies. I think the big one here is celiac disease. I deal a lot with celiac disease. I work a lot with celiac patients. All of these GIs, gastroenteritis and asthma, a lot of these are directly impacted from a baby not getting that initial seeding event from mom stool. There is actually a really cool researcher. Her name is Dr. Maria Dominguez Belo. She's incredible. And she has done some clinical studies where she has compared moms who have had C-section babies and then those babies are vaginally seeded, right? So some of the hospitals will swab the vaginal canal and then deliver that fluid to the mouth of the infant to basically help them be seeded by mom's vaginal fluids. Great. But then she's also looked at not only vaginal seeding, but also taking stool from the mom and giving that to the baby. So basically delivering a fecal transplant at birth for these C-section babies from moms. And what is so cool is when that happens, those babies who received the fecal transplant, not the ones who received the vaginal swab, but the ones who get the anal swab, the rectal swab, they get a little bit of mom's stool, those ones become more like vaginally birthed babies than the ones who even get vaginal seeding. So cool. Like the power of poop is so insane. I love it so much. I think it's like one of the coolest things on the planet. And I think it should honestly become standard of care if we want to start reducing disease burden in this country. There's another study that I didn't put in here, and I'm so sorry. I just like start talking, and I actually should have a timer near me so I can see how much I'm talking. I'm good. I'm doing all right.
Good. All right.
Um,
Good.
okay, thanks. Yeah, I was just like, I don't have a clock around me, so I should probably like make sure I'm not talking too much. But like I get so excited about this because there's another study that was conducted where they basically took these C-section babies and they delivered, like within a week of them being born, they delivered little aliquot slurries of stool from other younger infants. Not younger infants, it's more like 8 or 9 year old children. And those babies had the same outcomes, similar to a vaginally birthed baby, which is so incredibly like, to me, I just think in my brain, like in my like heart of hearts, if I could change the medical system in any way, I would have moms who are in their third trimester of pregnancy, hopefully before receiving an antibiotic during pregnancy. If we can avoid antibiotics during pregnancy, please let's try and do that. But what's really interesting is that if we could collect mom stool before she goes in to the birthing process, because we don't always know what's going to happen. We do know that a lot of times if there are complications, they'll go right in for an emergency C-section. But if we could collect mom stool, that mouthful of delicious yumminess that this baby would have gotten if they'd been vaginally birthed, and we have those slurries available just in case. Because if that mom goes into a C-section, that's often IV antibiotics, that's often a lot of different medical interventions, different drugs, different painkillers that are being just pumped into mom's system, right? But on the other side of that, we start giving that infant little aliquots of mom stool that was collected before she gave birth. I think we would see so many cooler outcomes in terms of long-term healthcare with these kiddos. So, soapbox moment. I just think it's really cool. I hope you guys do too. If there's questions about it, I can't wait. Let's have a conversation. And the nutrition, right? I think that what's really interesting is when I am able to, I love talking to donors, parents, and getting an idea of what was your pregnancy like? What was delivery like? Were you able to eat well? Like some moms go through like hyperemesis where they are vomiting all the time. They have a really difficult time even getting the foods in that they wanted to eat. I think that what's really interesting about this particular study is that they talk about the importance of nourishment and a healthy, varied diet and how important that is for creating a nice, healthy epithelial layer inside of the intestines of these infants. And this is the first 1,000 days, right? So it's basically preconception to pregnancy to having a baby to 2 years old with the infant, and how important all of those years are in terms of the health and development of this child. And so if I can talk to donors' parents about like what were their first years like, was it if they were sickly kids, I don't want them in my stool bank. But if they're like nice, healthy, happy kids, maybe they have an earache here or there, and like mom treats them with herbs or breast milk. Breast milk like nature's miracle. Like you can squirt it on everything and it literally does all the stuff that you need to help heal most infections. Like I just think it's really cool. So the importance of the first 1,000 days, I highly recommend reading that study if you guys are working at all with pediatrics. But it brings me to another case where I had a patient who was pregnant, and she actually she was in her 22nd week. Cool. I'm so glad I wrote that down. I was like 22nd week of pregnancy. And what was really interesting about her, so she had had recurrent C. diff. She'd been dealing with it for about 7 months. She'd been through 3 rounds of Vanco, still testing positive for C. diff toxin, basically on antibiotics most of her pregnancy, which is tough. Like she got C. diff, she started treating, she got pregnant, she continued treating, and she was not dealing with it. She'd previously dealt with IBS symptoms. She'd had microscopic colitis. Food intolerance is a very common part of her picture. But she was my first patient that came to me pregnant with C. diff, desiring FMT. And her biggest concern was potential miscarriage. And there's not good data in the literature for me to say, you're fine. I didn't know. I wasn't sure. So we had a big conversation about it. And we talked about all the pros and cons because her not treating could put her infant in a significant risk history. If that child was vaginally birthed, that child could take a mouthful of C. diff toxin laden stool. And having an infant's biome start out at that much of a disparaged degree of microbiome degradation, depletion, quorum sensing, infectious agent, thinking about all of the stuff we just looked at and how important it is to have good nourishment for the first 2 years of life in order to sustain a healthy, happy biome throughout the rest of your years. We talked a lot, and she was like, I'm in, let's do it. Let's see what happens. And so because she had recurred multiple times and was having such a difficult time, I wanted to make sure she was going to be clear of her C. diff. I'm finding in my private practice that people are becoming more, or C. diff in general is becoming more virulent, it's becoming more resistant to treatments and therapies. And so I am finding that if somebody has recurred more than 3 times, I almost require 2 30 cap doses of FMT. If it's their first recurrence, I might go with one, but it's coming to a point where the more the merrier in terms of getting as many microbes in as we can. So we treated her with two doses of fecal transplant because she was pregnant. I didn't really add a ton of other things into her treatment plan. I did do some Blvd and I did do some L-glutamine just to help support the lining of the intestines. And what was really interesting is she, 2 weeks after treatment with me, testing negative for C. diff toxin, she was still experiencing diarrhea, which does happen. Post-infectious IBS is very real. I work a lot with that on the other side of fecal transplant. I do a lot of education around that for patients who are seeking fecal transplant. Sometimes they can go right into a solid stool and they're like cured, they feel great. A lot of them will have on and off solid stools, and there's a lot of anxiety following C. diff. A lot of people get really anxious. They can smell it. They think it's coming back. There's just a lot of fear that comes on after C. diff has been part of their picture. So just something that I'm often working around. But a month and a half after therapy, and mind you, this woman's been dealing with IBS and like inconsistent bowels for 10 plus years prior to getting fecal transplant. But she had her first solid stool 1.5 months after therapy and before giving birth. She also carried that baby to 42 weeks. Had a very healthy baby boy. I got all the pictures sent to my inbox, which was awesome. This is clearly not that baby boy because patient privacy, but she was stoked, and he's a super happy, healthy 4-year-old now. So very cool. One of my favorite patient stories. And stool, it's so cool. I love it. It's the best. And we live in a world where your access to it is shitty, unfortunately. In 2013, the FDA actually registered FMT as an investigational new drug, or an IND, meaning that if you wanted to use it in practice for anything other than C. diff not responding to standard therapy, you needed to have a clinical trial in order to allow that to happen. In 2016, they drafted some guidance that never actually got released in terms of becoming official documentation, but they did at one point discuss having a requirement that donors must be related to the patient. There's issues with that. A lot of people don't have healthy relatives. So there was a lot of pushback. It never actually went through. And in 2022 was a really big time for the fecal transplant space because that was when Rebiota, the first drug-derived fecal transplant option, was approved that November. Within 3 days of that drug approval, we have a pretty tight, small community of fecal transplant providers. So we're all sending out the FDA guidance, and they basically were like, no more stool banks, no more distribution. Prior to November of 2022, if any of you had a patient with C. diff in your practice and you wanted to treat them, I would ship FMT to you. You would be able to deliver it to your patient in your office, and we would call it a day. After November of 2022, that no longer could happen. So in order now to make fecal transplant, if you are somebody who wants to do it in your office, you have to be the one who identifies, screens, curates, and delivers the FMT. There can be no middleman, no other person doing it. It has to be you, yourself, and you as the provider delivering fecal transplant. So my weekends are in my poop lab, and I spend a lot of time curating some delicious slurries for patients, which is, I love it. I think it's really cool, and I want to be able to keep it around. I touched a little bit on prepping for the biome, and we'll get a little bit more into that, but really understanding how C. diff, how severe C. diff really is. People who have recurrent C. diff infection, generally they're coming, people who are, people who get C. diff are people who are coming off of an antibiotic, usually. Usually I'm getting women who are post C-section, people who are after a car accident. I've had people get it after a cat scratch. I've had people get it after all kinds of random things. They show up to the hospital, they get an antibiotic. I honestly think it's transmitted to them in the hospital because there's some really interesting data. It was a Medline study or Medscape study out of 2018 or 2019, where they looked at industrial laundered bed sheets in the hospital setting. And they basically found that once they've gone through the industrial laundering system, 60 to 80% of the spores still exist on those bed sheets for C. diff. So it loves to stick around. And I just feel like the hospitals are petri dishes for C. diff. And then recurrent C. diff is that if you are somebody who had an infection and then 8 weeks later you have another infection, you're considered a recurrent C. diff person. It may be the same strain, like you could be somebody who got reinfected by the same strain because maybe you didn't clear it out enough, or maybe you now have a new strain. Generally, patients who are initially responding to an antibiotic therapy, they'll do fine for a period of time. They get a pneumonia or they get some sort of an infection, they get an antibiotic, they recur. Any person who has had C. diff is now at a higher risk of getting C. diff again. So each subsequent recurrence that a patient gets, they are at a higher and higher and higher risk of recurring again, which is one of the reasons that I think fecal transplant is so cool, because we don't actually see those numbers with fecal transplant. Because again, we've created a whole new biome. And what's really cool is oftentimes, not always, but most of the time, when I'm retesting after fecal transplant, not only is the C. diff toxin going away, but the PCR for C. diff also shows a negative result, meaning they're not even finding the genetics for that species inside of the gut, which is pretty cool. And then quorum sensing. We've talked a little bit about quorum sensing. We're going to talk about biofilms because they're really, really important. And we will get back to quorum sensing a little bit more. But biofilms, we all know kind of, they're like, I just recently got introduced to the whole Harry Potter series. I know I'm like a decade behind. It's fine. I'm usually pretty much behind on everything, so I'm fine with it. But the invisibility cloak, I kind of think of the invisibility cloak being the biofilm, right? Where like all these microbes come together, they do everything they can to basically build a fortress to make themselves invisible to the medications that are coming in to kill them. And so they've got all of these different like, polysaccharide layers and different metals that are incorporated in there. And I think what's really interesting is that if we can't break those down, a lot of times that's contributing to the recurrence aspect for these patients, because we think we've killed it with some Vanco. The second that Vanco is gone, those microbes are still talking to each other. They're still sending out their quorum sensing capabilities, and we just wiped out more of the population, so now they can continue to talk to each other. So I do think considering biofilm disruptors, if you have the time and you're working with somebody with C. diff, getting a biofilm disruptor that has a quorum quenching property to it, so like EDTA as an ingredient in the biofilm disruptor, can be a really, really nice addition to helping support somebody in their antibiotic therapy and then prepping them for something like FMT if it moves to that. In order to prep for FMT, I generally have my patients discontinue their antibiotics 24 hours before we do the fecal transplant. So I'm always doing fecal transplant in the morning because they've slept and I want them to at least be 12 hours fasted. That's ideal. The day before FMT, I want them to do more of a liquid-based diet. I don't require any sort of like laxatives. I don't require any sort of cleansing of the bowels other than like gentle foods, which is generally liquid based, right? So anything that's been blended, easier for it to just kind of pass through the digestive tract, that's what I'm looking for. I want water based foods, I want liquids, I want soups. Coffee's fine. Everyone asks about coffee. It's fine. Take and drink it. I don't care. But day of fecal transplant, I want them only doing clear liquids before the FMT. So they wake up in the wake up in the morning, and if they want some water, they can have some coconut water. They can do some teas. I'm fine with herbal tea. That's fine. Morning up. So I guess it's not clear liquids, but I'm okay with herbal teas. And then basically they've got a 60-minute period to swallow 10 to 30 capsules, depending on what our treatment plan has ended up being. And then they can reintroduce solid foods. I generally push for 2 hours after the FMT. If they get nauseous, I will let them eat before then, because the last thing I want is somebody vomiting up triple encapsulated capsules. Not what I'm looking for at all. Again, for day of, I do have them avoid coffee because it can speed up transit time. I don't generally want them to have a sped up transit time. I will talk to them about decaf coffee day before, but generally day of, we don't do coffee, we don't do spicy foods, we don't do anything that's going to make them want to have more bowel movements. Sometimes I also add in Imodium just to help slow transit. So and everything else, I have them wait for medications for at least 2 hours after FMT, unless it's thyroid. Case 3, we're just like diving into the shit head first. So this woman was a female in her late 50s. She had recurrent C. diff infection. She was on hospice. She had recurred so many freaking times. She went through 2 rounds of Flagyl. I do not recommend Flagyl on any level. Flagyl has one of the highest recurrence rates associated with it. So if you do see C. diff coming into your clinic, please just don't. Stay away from Flagyl, metronidazole. Please don't. 1.5, sure, sorry, so 1.5 rounds of Difficid. That being because she did okay with the first round, second round she did not tolerate. So she had been through basically 3 rounds of those therapies and then 3 more rounds of vancomycin. Meanwhile, in the background, she was diagnosed with primary immune deficiency. She had had COVID. She came out of COVID with restrictive lung disease. So she had no breath sounds in her middle or lower lobes. She had babesiosis. She was struggling with recurrent UTIs. She was on hospice. They basically told her, like, you're dying, right? Like, sign like all your paperwork, cross your T's, dot your I's. You're not going to get out of this care. And so she had 120 days of nonstop diarrhea before her clinic had contacted us. And this was prior to 2022. So this was not my patient. It was a doctor that we had coordinated delivery of fecal transplant with to his clinic. And what was interesting is she'd also had 16 pounds of weight loss. So we got all of her records after, which was really fun. We had her treated. So we advised the doc on the case. We talked about doing 30 capsules in a divided dose. This was, again, kind of earlier in the C. diff world. She couldn't afford more than 1 dose. So what we decided to do was break it up into 3 days so that we could have more frequency. Sometimes that's what it takes with FMT2, is to have more of a frequent, consistent dosing rather than one big bolus dose. I like the big bolus dose. If my patients can afford to get 2 doses, I like them to do a 30, 10, 10, 10. That's like such a sure win result for me. But sometimes people can't afford that. And she was on hospice. Her family wanted her to have death with dignity. It was really important for them. And so we did what we could to kind of work around and dose in a way that would help support that. The coolest result with this woman, she took 10 capsules after her first day of FMT, 10 capsules, just 10 capsules. She coughed up a mucus plug that she described to be the size of a softball. That's freaking huge, right? Like, insane. Now, all of a sudden, her middle and lower lobes had full breath sounds. She had no more drops in her O2 sat since she coughed up the mucus. She had no more drops in her blood pressure. She was still taking supplemental oxygen, but her energy was like climbing through the roof. And she made a statement to us because we actually checked in with her after the fact because it was such a like we were so blown away with it. And she said, I don't feel like I'm dying anymore. And truth of the matter was she wasn't. She got discharged from hospice care and she is now still living a very happy, healthy life. And that was about 4 years ago at this moment in time. So one of my favorite cases for FMT for sure. And like it had that impact on her lung tissue, which just makes me like so many questions, right? Like, what in the world is happening between the gut and the lungs? Like, how are these two systems related to one another? The gut is the center of everything. And that's one of the things that I've come to find and learn about microbiome health with FMT is like, there's nothing that's not related to the gut. And so the coolest thing is like, I can use something like FMT and I can really shift somebody's internal environment basically overnight. And I can see some insane shifts on the next day. And it's like, can I explain how that happened? No, I can't tell you how or why she coughed up that mucus plug after 10 capsules of FMT. But she was clear of her C. diff after getting the FMT, and then she was discharged from hospice. Like, you gotta be freaking kidding me. Shut the front door. So cool. So I love that. Support after FMT, there's lots of things that can be done. I get this question all the time. Like, what do I do? Again, lots of anxious patients after FMT. I just want them to feed their new biome. They've got new bugs, they've got new critters in there. Like, the most important thing for them to do is look at fiber rich foods, sauerkrauts, kimchis, fermented options, go through some research on that. No to fast food. You guys already know why. It's ridiculous. We should all say no to fast food. And how to protect from C. diff recurrence. One of the most important things that they do to protect from C. diff recurrence is to take an FMT. But on top of that, Saccharomyces boulardii, incredible option. I also don't mind a consortia probiotic. I think probiotics can be really helpful. My big beef with probiotics is when people stay on the exact same probiotic over and over and over and over again for months and months and months on end. I don't think that's how probiotics are meant to be administered. I really do think it's about mixing them up. So if you find like a brand that you like or different ones that you're interested in, maybe there's 3 or 4 that you can kind of rotate through. I like the idea of doing like take one bottle, finish that. Awesome. Let's move you to this bottle, have you do it for a month. Awesome. Saccharomyces boulardii is a little bit of a different beast because it's actually a yeast. And it's got insane data for helping. Number one, it can help actually people get over their C. diff without FMT, which is awesome. But two, in terms of helping prevent recurrence, I just think it's really, really important to have that microbe. So do it. And then intestinal lining repair, like these are kind of some of the basics. ACE, I love vitamins, A, C, and E. I love zinc, I like copper, I like selenium. I like postbiotics. I think all of them are great. You can get postbiotics from your fermented food, believe it or not. And then lifestyle, like you gotta sleep. Sleep is where we heal. If you are not sleeping, that is the first thing I'm going to work with patients to make sure that they're doing, because I can't get anywhere with somebody who's like, yeah, sorry, my life is stressful. I don't sleep. I get 5 hours if I'm lucky. Like, yeah, no wonder your health is crap. Like, until you can prioritize yourself and get yourself sleeping better, I'm going to have a really hard time getting you to the place you want to be. And so it's really about helping empower patients to get them excited about taking care of themselves. And the coolest part is I get a very non-traditional patient coming to me. Yes, I'm a naturopathic doctor. So the people who are seeking naturopathic doctors, of course, they're like trying to do all that stuff, which is really cool. And I love that. But when I get like the, person who lives out in the sticks and like they could give excuse the language, for like 2 shits about taking care of themselves, or they're out on a tractor all day, or, they're in the middle of pesticide haven. Like it is so cool to get to start taking out some of those big influences in their world and see those shifts, because then they're like, oh man, this actually does make a difference. And you're like, yeah, it's like the coolest thing ever. So I love it. This is a really cool study, I just think, across the board. They basically did a research trial where they were looking at diversity and looking at different microbial species and trying to see that in a week, if you eat less than 10 plant foods versus somebody who eats more than 30 plant foods, how does that impact your microbiome? Turns out the more vegetables or plant materials that you can get in a week, the better. Our bugs like the diversity, they like the different polyphenols, they like the colors, they like all the different fibers. So what I tell patients too, because like they'll be like 30 different plants, you've got to be kidding me. And I'm like, tea counts. Tea counts. You get polyphenols from your herbal teas. Get really good at drinking herbal tea, and you can accomplish this in no time. Spices count. Like, get exciting in your kitchen. Like, maybe you try like a little bit of turmeric or saffron or something that's a little bit outside of your norm. Like, maybe you're going to do some clove or some mustard seed. All of that counts. So, playing in the kitchen and getting a little bit more excited about different spices, great way to get to your 30 plants in a week. Huge fan, huge fan. Love that study so much. This was the Fee Fi Fo study. It's like abbreviated to be that, but it's basically feed more fibrous food. Um, the cool part about this study was that they actually were looking at, people who eat a high fiber diet versus people who eat a high fermented food diet. Turns out fermented food is like the best thing that you can put into your digestive tract. It can significantly decrease inflammatory markers and it can increase your microbial diversity. So when people come to me and they're like, what can I do? What can I eat? And it's like, there are some people who can't afford all of the fancy supplements, or they can't afford to move out of the moldy environment, or to get out of this, toxic sludge next to a highway where they're inhaling benzene all the time, like all the different factors, right? And I'm like, commit to fermented foods. Get like a really great fermented food. I mean, my local Costco, you can buy those big containers of like the wild ferment sauerkraut. It's got like garlic and cabbage in it. Incredible. Take some of that, have like a forkful every day if you can tolerate it. If you can't, let's work to get you where you can tolerate some fermented foods. One of the best things that you can do for your microbiome, especially on a budget. And I'm all about microbiomes on a budget. This is just a nice study to show how Saccharomyces boulardii in a dose of 20 billion CFUs a day in conjunction with antibiotic therapy actually helped reduce the incidence of hospital-acquired C. diff infection, which is pretty cool. I'm a big fan of SAC, guys. Like, if you're not using SAC in practice, it's also incredible for people who have diarrhea, just kind of across the board. So I love SAC. Like, if I could pick a favorite bug, I don't know that I could. I don't, but I do use it a lot. We'll put it that way. I can't pick a favorite though, because I do think all of them are very important. And I have a really hard time talking about like the good versus the bad, because I think we have a lot of good when they're working together as a community. So again, this is a really interesting, these are just some references to look at as to why vitamins A, C, E, zinc, copper, selenium, and postbiotics are really helpful at feeding the epithelial tissue. One thing that I would like to point out about vitamin A, just in I actually really appreciate. So I think vitamin A is like such an underrated compound. Yes, be careful with it in pregnancy. But if you can get vitamin A in, I think it's a very important compound that's kind of undervalued. And postbiotics, like I'm sure you guys have heard a ton about postbiotics. They are kind of like the new hype in the microbiome space. If you're eating 30 different plant foods in a week, you are up in your postbiotics, because postbiotics are essentially the poop of the microbes in your gut. So they take all of the fibrous materials, all the polyphenols that we're sending down the tube, and they gobble those up and they poop out postbiotics for us. So short chain fatty acids, bactericins. Bactericins are the freaking coolest thing ever. Like, again, this is where I kind of come back to that concept of, do we have infectious agents, or is it really we have an imbalanced microbiome that's no longer making the appropriate antimicrobial compounds, which are what the bactericins are, to keep those, opportunists, or just kind of like the hooligans in the environment, right? Like they want to come in and they want to do their thing. fine. But the bacteriocins, if they're being produced, it keeps them in check. It's kind of like having like a little community force. It's like, hey man, you can't do that. Um, Microbes also make vitamins. I think we're all pretty aware of that, but I think it's a pretty cool thing. B vitamins, huge source comes from the microbiome. Also K2, right? When we think about vitamin D3 and the importance of K2 in terms of getting calcium into the bones, our microbes make that. They love that. They also make a bunch of different neurotransmitters and neurotransmitter derivatives. So a bunch of tryptophan derivatives. They can help with dopamine. They can help with all kinds of different wonderful signals to our brain. And then the exopolysaccharides, what's really interesting about them is that the different genus of microbes, so like, whether we're talking about lactobacillus or bifidobacterium, they're starting to find that some of the different EPS molecules that are coming from those different genus, some of them are immune modulating, some of them are anti-inflammatory, some are actually like shutting off tumor oncogenesis genes, which is pretty cool. So again, microbiome plays a huge role. We make a lot of these postbiotics, but you can also take postbiotics. We can talk about that too. But what I think is really, really cool is that remember that slide where we're talking about how unique you are and how it doesn't really matter. Just because you're unique doesn't mean you're useful. But what's really interesting is that this study that was conducted, there were over 1,000 people in this research trial. And what they did is they swabbed like it was like 13 different locations on men and 15 different locations on women. Actually, I think it was 15 on men and then 18 on women. There were 3 more locations on women because they did multiple vaginal cervix swabs. But what was really interesting is that they were able to take all of these different swabs with all of these different regions. And basically, if you look at A, the row A up here, and you look at all of the different phyla for the microbes, you see a lot of variation. There's a lot of different microbial names for different parts. And this down here kind of shows you. So this is the anterior nares of these over 1,000 humans. This is the buccal mucosa, tongue, stool, all kinds of fun things, right? So they do all of these measurements and they're checking to see like, who's there? Who are you? But what's interesting is when they sequence further and they look at the metabolic pathways, they're looking at the different pathways to create metabolites, it actually all kind of starts to become the same. So the name of the bug does not really matter. It's what the bugs are making that matters the most. And I think that kind of like helps everybody take a deep breath when we start analyzing, when we start getting into like stool testing and looking at stool cultures and seeing like who do you have in there? Oh no, this is a bad guy. It's like, is it a bad guy? Or are you actually able to create the metabolites you need? Because we have things like horizontal gene transfer, which is a way for 2 microbes to line up next to each other, like my bentonite clay. I pre-make it because sometimes it's a pain in the ass to make. And then this is some chapstick, right? But let's say that these are 2 different microbial species. And what's really interesting is that if this one carries a gene that say it makes butyrate, right? And the system, like the internal environment, is low on butyrate. These 2 can line up next to each other. And this butyrate producer here can pass that butyrate producing gene to this microbe over here. And this might be like a Firmicutes. But now it has the ability to make butyrate. I think we forget that. I think we forget that the microbes talk to each other and they're so much smarter than we are. And we're doing everything we can to figure them out, but like they're a million years ahead of us. And I think that's one of the coolest things the microbiome has taught me too, is like we know a lot and we know so very little, which I find it to be very humbling. This is a research trial that was done on postbiotics. So it was a postbiotic preparation that was made from Saccharomyces cerevisiae. And what's really cool is, again, if we are just taking these small molecules, these byproducts of this fungus, eating from like a brewery or like a slurry, right? They're eating from a broth and essentially pooping out their postbiotics. We actually saw improvements in antioxidant capacity and increases in T and natural killer cell, not only production, but also getting them to the tissues that we need them at. So Postbiotics are important and they are so incredibly cool. And you can get them from a really healthy diet. I always tell my patients supplements are to help supplement a healthy diet and a healthy lifestyle. Now let's talk one more story, and then I think we're getting close to the end. I promise I'm not going to talk your guys' ear off the whole evening.
You're
But
doing
this is
great.
okay.
Doing
Woohoo! Great. Oh, fantastic. I can't see any of your faces, so it's such an interesting thing to like just talk to my PowerPoint slides and know that there are people on the other side, but I'm like, all right, here we go. I love it when I can like actually see you guys, but we'll get there. So this was another FMT case that I had, and this was a woman who had, she was in her mid 30s when she came to me, but when she was in her late 20s, she actually ended up having a full resection of her large intestine. So a pancolectomy. She had rectal bleeding in college. It just never stopped, went to fulminant Crohn's. That was the answer to her issue. In 2013, she was still having issues. She would struggle with pouchitis. She started Humira. She went into remission for a while. But every once in a while, that pouchitis would come back. And she was on long-term Cipro. She had Flagyl treatment, which again, I think I talked about how much I dislike Flagyl. I'm going to say it again here. I have some serious qualms with that antibiotic. Please don't prescribe it. But she was taking antibiotics basically to try and manage her pouchitis, led to C. diff. She got diagnosed in 2014, was recurring in 2015, wasn't responding, had 2 rounds of Vanco. And what's really interesting is she actually went to OpenBiome when OpenBiome was still around. OpenBiome was a big stool bank on the East Coast. They were kind of like the purveyors of getting Rebiota up and running and making their drugs. So they were a big part of helping assist in that research. And once the drug came out, OpenBiome's kind of like petered away a little bit. But she actually was able to take FMT capsules even with pancolectomy. So she was an interesting case because to do FMT capsules, generally FMT capsules are triple encapsulated. One of the reasons for that is that 2 layers of gel cap has been shown to sustain 122 minutes in an acid bath of hydrochloric acid. We know it's going to survive the stomach. That last layer is generally going to be enough to get it mostly through the small intestine and likely to deliver at the end of the small intestine, beginning of the large intestine. Because she didn't really have a beginning of a large intestine for us to get to, we needed to make sure that that last capsule would open early enough. And so what was really interesting is when she came to me, she, and I think I'm kind of getting ahead of the story, but I think this is interesting. So I'll get back to it. But basically, what was really interesting is when she had first worked with OpenBiome and she had done her FMT capsules, they actually had her take the capsules out of the freezer, let them thaw a little bit, which is definitely what I tell patients not to do. I'm like, you pull it out of the freezer, you put as many as in your hand as you think you can swallow. You put the rest back in the freezer until you've swallowed those, and then you go back to the freezer and you grab more. If they want, they can get a block of dry ice and put the bottle on dry ice. I do recommend having a layer of like paper bag between the dry ice and the bottle because I have seen a bottle or two explode. you know, par for the course here. It's what I do. But what's really interesting is that she was actually advised to let them melt a little bit. And one of the reasons for that is that you've got all these live microbes inside of that initial layer of the capsule. And so when you've got all the live microbes there, they start to degrade that inner lining of that initial capsule. And so the thought process from OpenBiome was if you do that, then by the time those top 2 layers are degraded in the stomach, we could likely get it to deliver kind of midway through the small intestine. And it worked. She was able to take it. She was C. diff free for 8 years. And then 2023 came. And she ended up getting a Campylobacter infection, had to have antibiotics. And then she found out that her Campylobacter was actually turning into a C. diff infection. She's got Crohn's, she's got PMDD, endometriosis. She had taken Vowst, so she had qualified to receive Vowst as a therapeutic, And unfortunately, the Vowst capsules, so Vowst is the second fecal transplant drug. I know we talked a little bit about Rebiota being released in November of 22. Vowst was released in March of 23. And Vowst is an oral capsular delivery of basically a pharmaceutical grade fecal transplant. And it's a four capsules. So it's less of a burden for people to swallow. But she didn't do great with it. She actually ended up having fecal incontinence and was still positive for C. diff. So she started working with me. She found me. We started talking. I was like, I have not treated a J pouch with FMT before, but let's give it a shot. I really appreciated her story from Open Biome. That helped me. We got creative with the treatment. We did kind of the same thing that they had suggested she do. We let the capsules melt just a little bit. She had done 2 30 capsule doses, mostly because her history. A lot of times with IBD patients, especially, FMT can flare the IBD. And so I have to be really careful with them. And I want to make sure that they have enough therapy at home that if they are to flare, sometimes we need to push a little bit more FMT to get them through the flare. Sometimes we got to put them on a steroid. But with her, I just wanted to make sure, one, that she had enough there and she had multiple recurrences. And like I said, in the last few years, I have seen the virulence of C. diff just become a little bit more aggressive. So I become more aggressive in my treatment. But because she had a J pouch and she has a quicker transit time, we also kind of veered from my standard dosing instructions. I did not have her do a liquid fast. I actually had her dose with a little bit of food. So in the morning, she would eat something like a small something, like maybe potatoes, because she knew potatoes slowed transit for her. And so I would have her do, just like maybe a half of a potato, eat that, then do 5 caps a day. So she did 5 caps a day for 6 days and waited because she just wanted to hold on to that second dose in case something else happened, because she was in and out of the hospital. She's constantly getting infections, constantly dealing with all kinds of different negative side effects associated with her pouch. And so she was like, I just want this here just in case. Even with that single dose, her C. diff toxin came back negative. Awesome. PCR, however, was still positive. So she is what I would call a carrier of C. diff. It cleared her C. diff from being an infectious cause from her diarrhea, but it doesn't mean that she's somebody who's now at a lower risk for recurrence. And I think one of the reasons for that is because she didn't complete both of the bottles. That could be one reason. Second could be she's in the J pouch world, which is just it's a new ball game. And I just don't think there's the same amount of exposure to the fecal transplant as somebody who has a full colon. So very interesting. But with her, we did biofilm work. We did S. Boulardii. Again, S. Boulardii all over the place. I love biofilm breakers with EDTA. We did that. Supportive nutrients, omegas, really a lot of omegas. She had a lot of anxiety, and she was on a lot of antipsychotic medications. Super low energy. We kind of worked through as much of that as we could. And I talked with her too, again, about this study that I had showed you guys earlier, because I think people they just don't totally understand the impact that antipsychotic agents can have on the microbiome. And for her, because she was recurring and she was struggling so much with these different infections in her microbiome, I see her as taking her antipsychotics. I see her antipsychotics as another delivery of another form of an antibiotic. There's some really interesting petri dish studies on different classes of antidepressants, just kind of as a subclass of the antipsychotics. And what's really interesting is you can actually see antibiotic resistance develop on the petri dishes, which is so crazy. Like, it's so crazy to me. And so for her, we had to have that conversation. She's got PMDD. She has a lot of mental health disparity, and discussing different ways that we could approach that. Like, this is where I'm not really afraid to have a conversation with a patient about, like, have you considered some of those more alternative realms of, like, maybe exploring like a shamanically led psychedelic session with somebody, and working with somebody in a way where you can really start to address, like, what is it that's creating these deeper moods for you? Because her medications that she was taking were not helping her picture. And what's really cool is like FMT, we talked about this too, because she qualified for FMT. So she's like, well, what if I just use FMT for depression? And I was like, I mean, there's evidence, like there is evidence in literature that FMT could be a potential curative for treating psychiatric illness, which is really cool to think about. It's just expensive and it's difficult, right? Like she had kind of an entry ticket. She's still in and out of the hospital for all kinds of other stuff that she's dealing with. So I'm kind of like adjunct care in her case. She calls me whenever something kind of rears up in her gut. But other than that, she's just dealing with a lot of other things. And so I think that if we can get to a place where we can try FMT for her for depression, that could be really cool. But I think about FMT and the potential of FMT for depression just kind of across the board, because the other thing we don't think about is when we're paying out our antidepressants, that's actually also inhibiting how our plants talk to each other. And any of you who are familiar with the herbalist, rest in peace, Stephen Herod Buhner, incredible herbalist. He actually wrote a book, and I can't remember if it was like The Secret Language of Plants, or I've got like 4 of them on my shelf, and I'm like, I can't remember which one it was in, but he talks about how our plants use serotonin signaling to talk to one another. And it's actually one of the ways that they tell each other that danger is on the way or danger is coming, right? So if there's like a fungus coming through the forest, the plants will talk to each other through serotonin signaling. A lot of our antidepressants and antipsychotics work by altering serotonin signals in some way. So when we pee them out 98% unchanged and they get into our waterways, our water systems, our rain, we're actually having a major impact on how our plants can communicate. So just something I think about a lot. It's my naturopathic side. But there's also some really interesting data on probiotics and depression. And I think what's really cool is in this particular study, there were 40 participants. They were either put into a probiotic group or a placebo group, and they were basically dosed with 2 grams of a probiotic for 4 weeks. And what was really cool is that the probiotic group actually showed significant reduced reactivity to a sad mood, which is kind of cool. So again, thinking about other ways we can support the microbiome. Not everybody can do a fecal transplant, but different ways that we can make that happen is very important. I really love mental health. It's a like small part of my practice as well. It's actually a large part of my practice because it's every GI patient has some form of anxiety or depression that I'm working with as well. But getting out in nature is also really important. I think all of us need more time and access to nature. This was when I was living in the Pacific Northwest. This was one of my favorite sunrise hikes. If I couldn't sleep, I would pack up my dog and we would drive about an hour and a half outside of Portland to this really cool location called Coyote Wall. And we would watch the sunrise together. And it was just like one of the coolest spots. So nature is really important, and our connection to nature is really important. And I think the microbiome helps remind us how important ecosystems are and how important diversity is and how important it is for us to be connected to nature, because the more we're out in nature, the more bugs we're interacting with. So that's my talk, my friends. I hope it was entertaining. I hope you guys are all still here. Let's chat.
No, we did great.
Awesome.
Wow. There's some questions in the chat and there's some online, but first thing I want to ask you is, I mean, all the cases you brought were C. difficile. I mean, is that the indication or are there other indications?
At this moment in time, that is the legal indication in the United States. You cannot use fecal transplant for anything other than C. diff not responding to standard therapy unless you have an investigational new drug designation.
Why?
Is this the recorded portion or the non-recorded portion?
I can turn it off. Wait till later.
Yeah. I mean, I think the short and sweet of it is money.
Okay, that's fine. Yeah. You know, I don't think there's one person on here that hasn't been burned by something along those lines. So, okay,
totally.
All right. Yeah. So in the chat, there's a few things here. It says WRT screening potential donors without shots. Most have had polio vaccine, and with SV40, whatever that is. So, um,
Some have. I mean, parents of the donors for sure. I have a donor right now who is a 17-year-old daughter of a naturopathic doctor. The only vaccine she received was one DTaP vaccine when she was 2. Zero antibiotics in her lifetime. She's just like healthy, happy, living her best 18-year-old life. So she's one of my best donors. And then I just screened in another younger donor. He is 9 and he is the son of a naturopathic doctor. Zero antibiotics, zero vaccines, lives on a farm, eats organic. Parents have like biodynamic farming practices. They eat a lot of their own homegrown food. Like, I really do my best to find these people if I can. And so, the polio vaccine was, God, that one was an earlier generation. I mean, I can see the scar on my mom's arm. She's 75. She still has like the polio, or maybe it was a smallpox. Can't remember which one it was, but she's always told me stories about remembering lining up and getting the polio vaccine. But I definitely I think that one's out a little bit outside of the current generation. It doesn't mean it's not a pass me down from the parent to the kid to the next generation. Does that help? Does that answer that question?
I guess, yeah. Next question. EMR, EMF have any impact on the microbiome?
Oh, I'm sure. Absolutely. Yes. I don't have any current data on that to speak to, but I wouldn't be surprised. Yeah, for sure. I mean, I think about I've got some colleagues who are in practice, and I actually went on a hike with a friend of mine, and I took my cell phone because, I had like my stretchy pants on, and I like tucked my cell phone into the back part of my stretchy pants. And he was like, "What are you doing? Get that cell phone off of your body." Like, and then he was telling me about how his wife, because a lot of women will tuck their cell phones into their bras when they're walking or working out or doing things like that. A lot of women are developing different tumors and breast cancers in that region. I would not be surprised if it's contributing to some of the colorectal cancer we're seeing. A lot of people will tuck it into their back pockets. But I don't have current or recent research that could help me.
Okay. How do you optimize the constituents of an individualized microbiome?
How do I optimize the constituents of an individualized microbiome, like the metabolites? Is that kind of what that
I didn't
potentially
ask.
what that's
I'm
asking?
just reading the question. Jill, if you're on,
Okay.
if you're on, um,
Yeah, I mean, ultimately, I think at the end of the day, it comes down to diversifying the different types of foods that we're eating, right? So when I get patients who come into my office and they're on like a specific carbohydrate diet, or like, God, the low fat FODMAP diet, one of my least favorites, yes, it can help with symptoms, not a great long-term plan. And my biggest thing is trying to diversify their diet and get them back to eating food without discomfort and pain. So low and slow is my favorite approach. Like if I've got people who are very restricted in their diet, I'm not introducing multiple new foods. I'm asking them, what food do you miss the most? And then they answer that question. They're going to try that food for one day that next week, see how it goes. If it goes well, we're going to call it a safe food. They're going to start to incorporate it the next week. What's the next food you miss the most? When we have people who are restricted to like 6 or 7 foods, sometimes the thing they miss the most is green beans. Sometimes it's broccoli. Sometimes it's a sweet potato. And so it's not like they're missing sourdough bread, even though sourdough bread is delicious. It's they're missing real food. And so I really try to help alleviate some of the anxiety around it and get them, cooked foods, then going from cooked, if you can start to tolerate more cooked, maybe you can try a little bit more raw. And it's really a stair step to get them to eating more and having their mental health be in alignment with doing that as well. Because when people go into eating afraid, their vagal response is, this is not safe. And if it's not safe, then that communication to their gut is also telling them this food is not safe. And so having that conversation too, where it's like we really have to retrain the brain to retrain the gut to be able to accept some of these foods. So low and slow, but I'm a big fan of diversifying and getting in all the ferments.
Okay. How would colonic therapy factor in the microbiome?
It's a good question. I mean, there's a lot of people who are doing, like colon cleanses, coffee enemas. I think that they're fine as long as they're not done in excess. There's a lot of people who get really excited. I had one patient actually who came to me wanting FMT. She did not qualify for FMT. But she had gotten really on to like the coffee enema kick and was super excited about it, was doing it daily for like months, and then started feeling like full body inflammation, heat. Like she just had like this inflamed hot rush through her body. We tried to work her up for Lyme. We tried to work her up for mold. We tried to kind of figure out like what could these other things be. And I think she just depleted her biome because it does wash out some of the biome. And I think if we do it too aggressively and too much, there is always a too much, right? And I think with her, she kind of went rogue, tried to do enemas with her sun stool, didn't actually respond well to her sun stool, which was something that was her case was very interesting. She was a loss to follow up, so I didn't really get to see how that turned out. But I do think because she was doing daily coffee enemas for months on end, she created a problem. So I do think that there is such thing as too much, but I don't think that they're bad. Is that you can do them here and there.
A comment from Dr. Mankins. Your enthusiasm is contagious, and what a great presentation. So there you go.
Oh,
Thanks.
thanks.
A pat on the back. Just a comment. Smallpox and polio. There were oral smallpox and polio vaccines somewhere along the line. Dr. Layson says, I am a general surgeon in the Philippines. I'm a post-total colectomy, ileorectal anastomosis for massive LGIB for matted diverticulosis in 2018. She changed her diet to vegan, 90%. Can FMT help her?
That's a good question. That is a really good question. That is a question where I would want to know a little bit more about the case. This is where I think FMT is, I think it's the coolest, right? And I don't think it's the panacea everybody thinks it is. I think it has really cool potential. And I think that for a large percentage of people who are really struggling, it could be that thing that kind of pulls them out of some pretty intense negative outcomes associated with what they're dealing with. And I don't always know that it's the right option. I think that what's really interesting about, I'd be curious about Ehlers-Danlos, especially when I'm looking at diverticulosis. Sorry, guys, you're getting me at the end of the day. I'm surprised I'm still talking, but we're doing this. We're making it through. I'd be thinking about connective tissue laxity and things of that sort, and really trying to get a better understanding of like the full picture there, because I would be very curious about other symptoms that are coming along. It's hard to say FMT will work for X specific condition. It really kind of depends on all of the other factors. So when I see my C. diff patients, I do a full intake. Like I want to know everything about their life. I want to know how they take care of themselves. I want to know what they're feeding themselves. I want to know what has led them to getting C. diff. So, there's a lot of other factors that come into play. Could it benefit? Possibly. I really think it has potential. But I also think that would be a much bigger, probably more private conversation, but potentially.
Okay, great. Is FMT available in Mexico?
I believe so. There's a colleague of mine, he's actually heading down to Panama. He has a clinic down in Panama. He is trying really hard to basically he told me this last week, he wants to become the open biome of Latin America. And so I do think that it's more easily accessible in Mexico. I don't know. There's one provider and I can like see his face, but I cannot remember his name, who is providing down in Mexico. And they don't have the same FDA regulations that we have here in the United States by any means. So that is helpful. There is the Taymount Clinic, which is UK based. They may have a location in the Caribbean. That's another place to definitely look at. What's interesting about tame out though, and it's one thing that I've thought about a lot because I think of fecal transplant like an organ transplant, right? So it's like we've taken a heart from somebody and put it into the chest of somebody else. And I tell my patients this when they're going in for fecal transplant, like you're basically receiving an organ transplant. At tame out, they'll take stool from 10 different donors and homogenize it and make that into a treatment plan. And so I think about the potential implications of that, like our ecosystems are our own complete ecosystems. I don't always know if like if if you mix the Sahara Desert with the Arctic tundra with the deciduous forest of the Pacific Northwest, you start adding all these different ecosystems together. I don't know if that's a benefit or if that's something that might create some other issues down the road. And so that's one of my big things about Tame Out that I ponder, and now you can ponder them with me.
Okay. Dr. Nario, you have any online questions?
Yes, so Piper, you really dumped it in my email. No pun intended, but we got a lot of questions for you. Well, this
All
is
right.
for my personal, I guess, benefit. You mentioned that it's out of pocket, that patients pay for this. And you mentioned that it's only for C. diff, but if it's for out of pocket, can you actually do this for, I know FMT has been studied also in metabolic conditions and also other even cardiovascular problems, even as you mentioned, psychiatric issues as well. So if it's a cash-based service, can you apply it in non-C. diff conditions?
I mean, that's really where it becomes like a matter of licensure. It depends on what you can and can't be covered for in terms of your license. I will say that I think that there is some really cool potential for that. But I think that that is a conversation that I would love to have outside of a recording.
Oh, okay. All right.
Yeah, for sure.
Sure.
You know
Let's
what I
keep it
mean?
at that for
Yeah,
now.
for sure. Yeah, for sure. I mean, I
Okay. I
think
think
I agree with you wholeheartedly. We'll put it that way. And
all right.
let's talk offline.
So it seems like you inspired other clinicians here how to be certified for FMT. How can you be handling all the good stuff that you're doing and be
Yeah,
trained for that?
totally. So I was trained by an FMT provider in Portland, Oregon, Dr. Mark Davis and his counterpart, Dr. Carmen Campbell. They were working together at the time, and I really learned because I was a student and I was interested in the microbiome, and so I started learning from them, and then started my own fecal transplant bank in 2017. And so what was really interesting is I basically learned on site. There's no protocol for it. There's no like recommendations or labs for it. A lot of times it's kind of done behind the scenes. And that's one of the big issues that the FDA has with fecal transplant is that there isn't a way to standardize it. Like even with these drugs, right? One of the biggest issues, it took them over 15 years to get the drugs approved because they couldn't standardize the stool. They couldn't show the same replicable outcome or product at the end game of making the FMT. And so there's complications there. But I think that ultimately it kind of comes down to I do a double centrifugation process where I create my FMT capsules. I basically have a blender that's a glass mason jar. It's a metal blade. Everything's autoclavable. So I can create my slurry in the mason jar, and then I pour it off into clean, sterile centrifuge tubes. I do a spin cycle to pull out the fiber pellet. I pour off the supernatant into a fresh, clean, sterile centrifuge tube. I put that in for a second spin at a higher speed, longer time, and that creates my microbial pellet. I resuspend that in a cryoprotectant, and then from there, I have a microbial pellet that gets pipetted into capsules. So it's a hands-on process that I do inside my own small little side lab.
So when you say your lab, it's not your kitchen or your fridge, right? I hope not.
Nope, nope, nope. It's outside of food handling, and I have a separate sink that is not where I wash my dishes. Yes, that's so. But it's really funny. One of my colleagues who works in fecal transplant, he was like, "But it's all good microbes. Like, does it really matter?" And I'm like, I mean, probably not. But at the same time, I do try and keep it clean because it's
So
important.
no specific certification, no institution or school to be certified for that, right? That's what you're
Nope.
saying.
Yep.
Okay. I think it's one from these are coming from your slides. I mean, why not NSAIDs? I think that's the one for alpha diversity.
Mm. I don't know it's a why not. It's just how it showed up in the study, but you're definitely welcome to go dive in and read more. I don't know why not on NSAIDs.
Hmm.
But I mean, I think we all know opiates are definitely a contributor. Just there's lots of different drugs. So,
Okay.
yeah, sorry. Wish I had
I
a
think
better
it's
answer.
another slide question. Why thyroid meds as an exception? I think that's for your prep, or is that right?
Yeah, because their thyroid meds are generally taken on a pretty consistent time clock. People are in their, the thyroid is something that has its own little circadian rhythm. And so staying on top of the thyroid medication, I just don't want to disrupt that cycle. So usually I have people take that one specifically, but everything else I kind of keep the 2 hour, keep it away 2 hours away from the FMT.
Okay. You mentioned about you're not a big fan of flagyl. Then what do you prefer for C. diff, like Vanc?
Vanc. I definitely go to vancomycin first. And then honestly, the regulations for the IDSA for C. diff treatment is failing 2 rounds of antibiotics before you qualify for a fecal transplant. And I don't do that. If somebody fails 1 round, they go right to fecal transplant in my bank. Because again, the more they recur, the more likely they are to recur. And I just don't want to play the game. So I do my best to get them out of recurrence as soon as I can.
Okay. For Sac boulardii, can this be taken by healthy individuals, like your probiotics, or do you prefer pathologies with this?
SAC's totally fine for healthy individuals. If you're healthy, though, the thing that I think of with SAC is rotate it. Just rotate it. That's kind of my big message with all of the organisms is that if you take SAC for a bottle's worth, great. Take it, finish that bottle, try something else. If you felt better on SAC than the thing you tried the next time, go back to SAC. But I think that sometimes when we choose these like, 3, 5, 7, 10 strain probiotics, they're great and they're super helpful, but I just don't think that we know more than our microbiome knows. And when we're overloading the system with billions of CFUs of a small number of species compared to how many live inside of the internal ecosystem, I just think that we need to give it some time to regulate outside of those influences. And so I do think that taking one, take a break, taking one, going to sauerkraut, going back to the one, like mix it up. Don't get so stuck on one probiotic.
So you prefer single strains, is that what we're saying,
I
rather
love
than
consortia. I love consortia. I just I don't like to do the same thing over and over again. Does that make sense?
when you say yes, cycling Sac boulardii, like 1 month on and then 1 month off,
Yes.
right?
Hmm.
Okay.
Hmm. Unless they're
And
an active infection, then I will do like 2 or 3 months on.
okay. You mentioned about probiotics. What are your thoughts of spore versus non-spore?
Spore's great. I like spore, but I also like non-spore. I think there's benefits to both. I mean, the big thing about spore is that they're, acid resistant, acid tolerant. They can survive all of the influence of the GI tract, which is great. But like the majority of probiotics that are being curated or curated without or with a delayed release capsule or an enteric coated capsule. So they're going to survive the acid of the stomach as well. And I think that again, is probably one of the most well-studied strains. And it's cool, it's got a lot of information. But I think that what's fascinating to me is that a lot of people are getting really stuck on strains. And I go back to like thinking about horizontal gene transfer and the metabolites that these microbes are making. And like, does that specific strain really have that much of an impact? And then when you start to blend and combine them, they all work a little bit differently once they're interacting with each other, again, because of horizontal gene transfer. So I just think that giving the environment different exposures to different microbes can be really beneficial. And in some of the consortia, I would really love to start seeing, and it's something that I'm trying to push for at SFI, is if we could start doing some metabolite testing to see like what are the small molecules that these consortia probiotics are making, because maybe it's more the metabolites than it is the microbe itself. And if we start diving into that information in that literature, maybe we can have a better idea of like, what is it that's happening? Like, is there a lot of butyrate being produced by this particular blend? Is there a lot of acetate? Are there different tryptophan precursors? Are there different bile acids or not bile acids, because that would come from a human or a living organism, but like different things that are being produced by the microbes. Like, are they the actual key components of what are making probiotics work? And if they are, it doesn't mean probiotics are bad. It just means that we're going to learn a little bit more about why this particular blend or why this particular microbe is actually imparting the action we're seeing.
So since you mentioned about testing, so part of your slides also is you do an O&P. What about going into a deeper dive using functional stool testing? Is that also something that you've done or you prefer, or O&P is definitely fine?
Yeah, I mean, my like functional lab, I run through Vibrant Health. So I run their gut pathogen, mostly because they've got 6 multi-drug resistant organisms on their gut pathogen. And in 2019, there was a death, like a true death associated with fecal transplant because there was an ESBL strain of E. coli that was in a stool from a donor that was used in an IND immunocompromised trial of cancer patients. 2 of the patients ended up going into sepsis. 1 ended up not being able to recover from sepsis. And they ended up finding out it was this multi-drug resistant organism. And then the FDA came out with guidance for people doing FMT to start testing for multi-drug resistant organisms. So Vibrant has ESBL on their form. I also do MRSA through an anal swab through Quest. I do VRE and CRE. I've got a few different genes that I'm looking for. But the functional testing, I think that in terms of what I'm trying to do, like the functional testing, I more so like the more research-based aspect of that. So like I like Cosmos ID because they've got a beta diversity, they've got a Shannon diversity. I can go in and actually look at some of the diversity indices for the patient. I can get an alpha diversity, which is awesome. And so I really like that because that's really more information for me. And it's actually more research information because if you go look and see like what is the best alpha diversity score, good luck finding that. Like that doesn't exist in the literature right now. But I think it's a really interesting place to look and consider. I think that some of these bigger functional tests are really helpful when you're actually trying to help somebody get back to a state of health. But when I'm screening donors, these are people who don't have digestive discomforts or issues with their digestive tract. Like they feel good, they're solid poopers, they've got good energy. Like I'm not looking to try and find too much. I'm mostly trying to screen out like, is there anything bad here that I need to be concerned about? And I mean, I've had some really good looking donors who come back. Like I had one woman that I screened early on in my practice when I had first started my stool bank. She was awesome. Like grew up on a farm, worked with horses, just like epic. She was just in great shape, awesome biome, but tested positive for Yersinia. And I had to eliminate her, right? So I'm mostly looking for, is there something here infectious that I'm going to spread to somebody? Because that's an important thing for me. HIV, syphilis, HEPs, all of those. I want to look through all that for sure. But I'm not really looking at functional labs in that way.
Okay. You mentioned about rounds of antibiotics. I mean, I think the question here is, how do you consider a detrimental round? Because there are 3-day administration, 5-day administration, 7, 10 days. What do you consider? Or just even 3 days is not feasible?
I mean, it's not that it's not feasible, right? Like, if I, are you talking about for donors or just in general health?
Uh, I guess the question here probably would be for the donors. I mean, sure, you brought up general health. Like, I'm sure you deplete yourself pretty with 3 days,
Hmm.
regardless. But maybe for this is more for your donors.
Yeah, this is such an interesting question. So generally the general rule, so there's some decent literature out there that you can replenish what is lost within 2 months of taking like after you've finished your antibiotic, there's a 2 month period, your microbiome can kind of look the same as what it looked prior to. So if it's their first insult, I'm gonna have them take a break for sure. So I'd have them do, I had actually had one donor who had ended up getting a UTI, ended up needing to take an antibiotic, took nitro for like 7 days, and then we basically off-boarded her for 3 months. In that period, I also had extra fecal transplant from her and may have used that to help restore her biome back to what it was so that we could use her again as a donor. And that's something that I think about too when, in my ideal world of like how we could use this therapy, like I have thought many times about the like just how cool it would be to be basically like a poop reservoir for people who like you don't know if you're going to need an antibiotic in the next year. You don't know if you're going to get sick. You don't know if you're going to have to go in for surgery. If you go in for surgery, could we potentially harvest some of your stool and recover your biome on the other side? So you don't have to worry about that. You can just take what is you. And that's considered, autologous FMT. And there was a time in my previous business partnership where my previous business partner had gone to a meeting and ended up finding herself sitting next to an FDA regulator and asked the FDA regulator, like we're naturopathic doctors, we're licensed in our state, we're screening donors, like could we possibly do like autologous FMT? And he's like, absolutely not. Like if the FDA caught you doing that, you would be asked to stop, right? Like you would get that initial letter that says, please stop what you're doing. And that's kind of the answer to the original question earlier, too, is like, could you use this for all these other things? It's a cash-based business. And it's like, if the FDA doesn't find out, maybe, but you run
Right.
that risk because if they find out, that letter's coming to your door. And so it's everything that I speak to and talk about is definitely recurrent C. diff, not responding to standard therapy because of
Mhm.
those risks.
Right. So questions here about biofilm. I know you kind of started with EDTA. Would IV EDTA be also inclusive of that, or just oral EDTA?
I like oral just because IV somewhat bypasses the GI tract. And if I'm working with GI and GI based biofilms, I do want something more oral based. It's kind of like IV Vanco versus oral Vanco. Like I'm going to use oral Vanco, especially when I'm talking with my C. diff patients. IV Vanco doesn't do anything for my C. diff patients. So um, I think oral would be my answer for sure.
And other choices. I know there are like other biofilm disruptors like proteolytic enzymes, or even, yeah, I've heard silver can also be one. But do you have other choices for your biofilm disruptors?
Yeah, I mean, I think that all of those, there are different products out there that have proteolytic enzymes with EDTA. I mean, there's a bunch of different brands out there that have done a really good job of making different biofilm disruptor options. I would peruse them, check them out, see what they have to offer. But absolutely, I think proteolytic enzymes are great.
And how would you know, or even how long you're going to be treating your biofilms, and how would you know that if they're still present and you're done with it, ready to move forward?
Yeah, it's hard to know. That's a really good question. The answer is we don't. Generally, when I'm doing biofilm breaking, like I've got a patient right now who's prepping her biome for FMT. Um, And what's really interesting is that she's not somebody who tolerates antibiotics very well. So we decided to do, she had berberine at home. I'm always a fan of like, what do you have in your cupboard? Because I cannot tell you how many people come to me after having seen a lot of other docs who they have just like all the things in their cupboards. I'm like, what can we use that you have? And so we put in some berberine, and then I did a product that had proteolytic enzymes with EDTA as the biofilm disruptor. And basically, I did kind of like a quick titration up. So I had her do 1 cap. She's a very sensitive woman. So like 1 cap a day for 3 days. If she did that, fine. 2 caps a day for 3 days. If she did that, fine. 3 caps a day for 3 days. So like really kind of like moving her up. And then once she could tolerate 4 caps a day, and generally, if she got to multiple, it'd be like 1 in the morning, 1 at night. And then when she'd go to 2, it'd be 2 in the morning, or sorry, when she'd go to 3, it was 2 in the morning, 1 at night. And then when it was 4, is 2 in the morning, 2 at night, that type of a thing. And as long as she was titrating up and not having significant adverse feelings in her body with that, then we would continue moving forward until she finished the bottles, essentially. Because I like to try and go through a bottle and then immediately after I hit it with FMT. So it's hard to know like when it's appropriate. I just want to break it down enough so that the new biome has a chance to start competing with what was there.
You mentioned about supplements. What supplements should you not take with FMT?
A lot.
A lot?
Like, yeah, I mean, and it's not like you can't, you absolutely can. It's just, I have a lot of patients who are like, okay, I have like every single probiotic and I have, I've got my oregano oil, or I've got my like insert any SIBO formula on the planet. Like they've got their candibactin, or they've got their berberine, or they've got their ibergast, or whatever. Like they've got so many different compounds and they're like ready and rearing to go. And usually I tell them, keep it simple. The things that are going to help restore the epithelial layer, that's really important to me. Those are the things that I want. So again, those more simple product, ACE, love those. Zinc, copper, selenium, love those. Things that are going to be cofactors to help support that repair process. And supplements are supplemental to a good diet. And so once they've got their FMT on, I want them to start using food as medicine. I want them to start understanding what that concept means and start diversifying their diet as much as possible in short spurts and increments. Like a lot of these people will come to me not being able to eat double digits worth of food. Like they're on 6, 7, 8 different foods, and that's what's their safe foods. So I keep them on their safe foods while they're in the middle of dosing FMT. And then it's like, okay, now let's stop being afraid of food. And we do this by slowly bringing in new food options, because that new biome is generally going to help their body be more receptive to bringing in more food options. And so I definitely think that there's a huge benefit there for sure, in kind of like mirroring that course that way. And I also think that for probiotics especially, I will do Sac-Pilardi like pretty much with FMT therapy, alongside FMT therapy. But even then, like consortia probiotics, I hold off. I pump the brakes. I give them like at least 2 weeks, if not a month, without probiotic exposure, because they just got the most epic probiotic you could ever receive, which is a whole ecosystem of organisms. So to me, why would I be adding in more of like 12 strains when I can just let that new biome simmer and do my best to support it with food, fermented foods if possible, soups, broths, teas. I get my patients into teas, especially some of the stress relieving tea. Like lavender is incredible for C. diff patients because they are so anxious. And there's actually some really interesting research showing lavender being an amazing anxiolytic, right? And so if we can think about adding in some of these herbal allies and making them part of their day to day, like one of my patients was calling me almost daily for the 2 weeks following her FMT, and I got her on lavender tea. And she was only calling me once a week. That was a big change for her. And I was stoked about it. She was actually like, I love lavender tea. And I was like, that's amazing, because I do too. Like you just sold it for me.
Yeah, that's amazing, Piper. You actually flushed everything down. So we got all the email questions, and I
Great.
think it's time for you to
Yep.
promote.
Yep. I think,
Awesome.
okay. I
Cool.
think you've earned your keep here tonight. So
Awesome. Well, it's been fun, guys. I really appreciate
thank
you
you.
having me.
Thank you so
Thank
much.
you so much. If anyone has questions, like please send them my way. I know that I got kind of like you just got to get shady in this world sometimes with answering some of the questions, but I'm always happy to talk offline more about options and different things. So please
Okay.
reach out. Don't be strangers. We'll talk soon.
Yep. Okay. Thank you so much.
Yeah.
Just a couple of quick things. For the CME credit, we have it here in the chat. eeds.com/em/9622. I'll have it on the next week's email also where to get it. It's $30 for 2 AMA CME credits, category 1. Dr. Zarin posted her link on how to get to the homeopathic seminar on Friday and Saturday. And that's in the chat also, and I'll send out an email tomorrow on that. And lastly, some of you know that we actually started a research group, and they meet on Saturdays, 12 noon Eastern, 9 a.m. Pacific. And if you're interested in that, we'll get you hooked up with that, and everybody's welcome. There's about 6 or 8 have been participating in that. Next week we have MitoQ. Is that correct, Dr. Nair?
Yes, MitoQ. That's our famous CoQ10,
Yeah.
and they're going to present to us.
Sibodian Mitchell. That's who that is?
Siobhan.
You know, so that's next week. Dr. Piper, thank you so much. This was really fabulous. We will get you a copy of the video when it's ready, if you want it, and we'll send you the participant list also. Anybody else have
Awesome.
any comments or questions, complaints? If you have complaints, take it to Dr. Nario, or better yet, take it to Dr. Burgess. Not on.
Piper, I think you answered this. You recommend loperamide slow down GI peristalsis to control diarrhea.
Absolutely.
You mentioned that, right?
Yeah, absolutely. I do that, especially for my 15 plusers. Like if I've got people who have significant frequency, I am slowing the GI because I need that FMT to stay in the GI tract.
Do you have products that you promote, or you just wanted to present to us?
I mean, I work for SFI Health, so I mean, all of their probiotics I would recommend across the board. They do a really great job sourcing. I mean, their facility is incredible. I love their SAC. I've been using their SAC B since I was in school, so big fan of them. I love their micellized vitamin A. It's one of the most highly absorbable vitamin A's on the market, which I really appreciate. And just overall, they've got a huge portfolio, a lot of great options there. They used to be Clear Labs. A lot of people recognize the name Clear Labs. They don't always recognize the name SFI Health. So I really like them. And then, also just my own FMT world. So if you guys ever have anybody who needs FMT or is in need of some support, like please don't hesitate to reach out.
Okay. All right, Claire. I didn't realize that was you were Claire Labs. So
Yeah, it's wild. They did a big name transition. I mean, they got bought out 9 years ago, but then the world of the pandemic hit, and I think that everything just got kind of crazy, and it was during their rebrand. So nobody really realized that Claire is now SFI Health. And so we're doing everything we can to kind of re-promote that and re-push that it's the same trusted probiotic line, just under a different name.
okay. Yeah. So we have used
cool.
it. So,
yes. Yes.
I didn't know it.
Yeah, you had no idea. But they're great. I mean, and their whole Therabiotic line, Theraline is awesome.
Okay, in the chat is the links for the homeopathic conference over the weekend, and also the link for the CME credits. So, and you can always get in touch with me if you need it and you miss it. So, okay. So again, Dr. Piper, thank you so much for your expertise. And why wasn't I this smart when I was your guys' age, huh? What the hell happened? What was I doing? So,
You just didn't give yourself enough credit. I think we're all guilty of that.
no, I didn't know any of this stuff. It wasn't even on the horizon. So,
Microbiome hasn't been explored until like 20 years ago. Like we learned how to sequence, and all of a sudden we're like, holy shit, there's bugs. There's a ton of bugs. What? So we're learning a lot.
okay. Well, we will
Right.
lean on you to give us an update at some point in the future. And
Sounds good.
it's truly been a pleasure having you. And we're very impressed with your expertise.
Thanks, guys. Well, anytime. Let me know if you want me to come back. We'll do this again. Round two.
We will
Definitely, definitely.
we don't try to overburden you too often, but
Cool.
okay. So thank you
All
so much.
right. Sounds great. Thank you, guys. Have a good
Thank
night.
you.
Anybody
Thank
else
you.
have anything? Dr. Nario, Joel, anybody else? Everybody, thank you for being with us. The folks in the Philippines, thank you for being with us. I realize the homeopathic conference, I did a little math, starts at 11 p.m. in Manila, so I guess that's not very practical, but it is videoed, and we'll make sure that we have it available to you. So we'll do it that way. I'll see if I can get Dr. Zarin to break it up so that it's not just one long 7-hour thing. It does get to be a little tedious that way. So
I'll give you guys updates on Greece maybe next time. I'll gather up all my new info for everybody.
okay, all right.
I mean Germany, not Greece,
Say
Germany.
Greece.
I'm losing it. I'm
Okay.
still jet lagged.
All right, you probably have jet lag too. You just got in. Okay. All right, everybody. So thank you so much. Good night. Wait, I got one more message, and thank you, everybody. Okay. Oh, that's from you. Okay. Bye-bye. All right. Good night, everybody.